So good evening, everyone, and welcome. I think we'll make a start. I'm Ingrid Barker, and I'm the Group Chair of NHS Bristol Group, which comprises our two trusts, University Bristol and Western, and North Bristol Trust. Thank you so much for battling to be here tonight. I know there's a bus strike and all sorts going on, so the traffic's terrible as well. So particularly appreciate you making the effort to join us here this evening. And thank you also to those of you that came with information and stalls, the health checks, and so forth. It's really great to have the support of so many partners and community groups with us this evening as well. So thank you to all of you. We're going to be telling you a story tonight of what we've been up to over the last year, going up to April. And it has been the most incredible year. Together, the two trusts created a joint clinical strategy, which is all about bringing the best of the two organisations together to provide even better services for all of the people and communities that we serve, and to make sure that those services are equitable, accessible, respond to what matters most to you. And so that work is ongoing, but over the last year, we've made a really great start on that, so you'll hear a little bit about that. A really important recent thing that we've done to support that is to create a community participation group. So this is a group of people that we've encouraged to join us from a really wide range of backgrounds and communities and experiences. People with lived experiences of our services, community activists, third sector organisations who advocate for others as well. And they are going to be the touchstone for us to co-produce what we do going forward, to make sure we really understand what matters most to you and to be able to work with you to go the right way in the way that we plan and deliver our services. During the year, in order to support that work around the joint clinical strategy, we have formed the two organisations into a group, which is why I describe myself as the group chair for Bristol NHS Group. And the natural next step for us is actually to formally merge the two organisations. So that's where we're at right now. The two trusts are doing really well. If you watch the news or listen to the radio, you might have seen that last week the NHS trusts across the country were all ranked in order. And our two trusts have done really well. So both trusts are in the top 20 odd of 140 something trusts across the country. So we're really proud that I hope that you take confidence from that we are providing good services for you. And my colleagues in the two trusts, hope it gives you encouragement too, to know how well that we're doing. So let's think about this evening. This is what we're going to be running through. I know we're tight on time, so I'm going to encourage us all to try and stick to our time slots for these colleagues. So we're going to be going through this agenda, and at the end of the evening, we'd really love to hear any thoughts and comments that you've got, but we'd just like to spin through some information giving to you first. Let's have the next slide. So it's been a brilliant year. I only joined the two trusts last June, and so through the year, here's just a few photos of stuff that I've been doing, and I thought you'd be particularly interested to know about the visit of the Princess Royal, Princess Anne. If you cast your mind back just over a year, she had that horrendous accident at home in Gatcombe, and she actually was brought by air ambulance and then ambulance to Southmead, and we looked after her at Southmead for nearly a week. She came and said thank you, and that's what that photo is there. You'll be hearing later about our elective centre for surgical care. We're very proud and privileged that Her Royal Highness has agreed that we can call it the Princess Royal Bristol Surgical Centre. I think that is a real honour. A couple of other highlights. Here's Peaches Golding, the Lord Lieutenant, down here. She came and did a lovely visit to the Children's Hospital with me and has been a great supporter of what we're doing in the two trusts. I've been doing joint work. Partnership is really, really important to us. We cannot do anything without our partners, both in the NHS, social care and third sector partners as well. So here you will see me doing a partnership visit here. Barbara Brown, who is the chair of our community trust, our community organisation partner. I've also done joint visits with the mental health trust chair as well. Really important in terms of fostering understanding of one another's services and how we can work that together. And then where would we be without our charities, two of whom are at the back of the room today, League of Friends here, and all of our amazing volunteers. And I've really enjoyed working with those volunteers through the year as well. Okay, I think that is it from me, but we're going to move on briefly then, I hope. Sorry, Duncan, I don't mean to be rude, but the auditor's report. Now, this is specific to UHBW because it is a foundation trust, and won't bore you with the detail, but it's basically a different set of requirements for each trust on what needs to be reported in public. And so for UHBW, we do need to hear from our auditor. So over to you, Duncan. If you want me to step, it's that song.
Good afternoon, everyone. Delighted to be here. I'm Duncan Laird. I'm the Senior Manager at KPMG in Bristol. We are UHBW's external auditors. I've been the external audit manager for UHBW for the last 4 years. And we're here to, well, I'm here to present the external audit results for 24-25. If any of you were at the Council of Governors meeting for UHBW back in June, you may remember that John and I did a little presentation on the responsibilities of external auditors and what it is that we actually do. We have 4 main responsibilities as public sector auditors. The main one, obviously, is to give an opinion on the financial statements and check that the numbers are accurate and give a true and fair view of the performance of the trust. We also have specific responsibilities around to give what's called a value for money conclusion, which is an absolutely terrible name for what it is because it's not about achieving value for money. But I'll touch on that in a little bit. Then we do also do some work on behalf of the National Audit Office. That's the whole of government accounts work. And we do a review of the annual report, although it's not strictly covered by our audit opinion. So in terms of the financial statements, we are required to issue an audit opinion, and that is an opinion on whether the numbers in the accounts give a true and fair view of the performance and the position of the trust at the year end. We issue our opinion to the governors. That is who it is addressed to, although we do all our reporting for the audit committee throughout the year. Very pleased to say we issued what's called an unqualified opinion, which is that we found no issues with the accounts. We issued that on 24th of June, which was ahead of the deadline for NHS reporting at the end of June, which is a excellent result. We do obviously have the option as well of raising any recommendations for improvement. We didn't feel the need to raise any of those either last year as well. So again, very, very strong performance. We focus our testing in specific areas, those areas that we think particularly risky. We call those significant risks. We have 3 of those for the audit. These are very typical for what you see in NHS audits. So valuation of land and buildings. Land and buildings is a huge number in the account. It's quite subjective. It requires external experts to calculate a number. And we do specific testing of those. Management overriding controls is a standard audit risk you will find on every single audit file in the country. And we test those. And we particularly look at non-pay expenditure. Obviously, the trust as an organisation isn't in the road of generating income, but obviously controlling costs is key. So we do specific work to check that the costs are being reported accurately. Moving quickly on to what's called our value for money opinion. So this is really about, as a public sector body that is using taxpayers' money, we need to be satisfied that there are appropriate arrangements in place for the use of that money. We look at 3 specific domains. That's financial sustainability. So has the trust got good budget setting? Is it keeping track of its costs? Does it have a long-term financially sustainable future? Governance, how does it make its decisions? The right people getting the right information at the right time in order to make decisions? And then improving economy, efficiency and effectiveness, which is really focused this the last few years around partnership work and how does the trust work with the rest of the health system in Bristol to improve outcomes for the patient. Historically, we've not had any issues with being able to conclude satisfaction on that at UHBW, and again, that's the same case in 2025, so we didn't identify any risks that there weren't appropriate arrangements in place, which meant we were able to issue a clean value for money conclusion. Our commentary on the particular arrangements that we see in place when we're doing this work, we report on what's called our auditor's annual reports. That's the public-facing document that will be published on the Trust's website in due course. As I said, we do a bit of work on behalf of the National Audit Office, who have the unenviable task of auditing the Department of Health accounts as a whole. Those accounts are prepared by consolidating all of the NHS bodies into one set of numbers. And the National Audit Office asked us to do a brief piece of work to help them conclude that all that consolidation is working correctly, and there are no errors being found down at local area that could bubble up into a bigger issue for the Department of Health accounts. We didn't have to do a full set of procedures, we just had to do the basic set. Again, no issues with that, we reported all on that at the same time as we did with the financial planning. And then lastly, we have a responsibility to read the annual report, make sure that management aren't cherry picking all the good stories and that it is fair and balanced. There are some specific disclosures in there around the remuneration reports and the salary tables and pension tables, which are of particular public interest. We make sure that those numbers are accurate. We have a responsibility to audit those. But broadly speaking, we just do a sense check that everything that's required by the NHS to be included in the report is referenced in there somewhere, how it is a fair view of what's going on in the And as I said, our reporting of the work comes in two forms really. We report to the audit committee regularly. We do a final report, what's called our ISO 260 report at the year end, just to confirm all of those findings from the audit. Then that is summarised in our auditor's annual report alongside our commentary for the value for money conclusion. And that is a public-facing document which is published and available for everyone to see. I am happy to stop there for any questions, but given time, if there are any questions, maybe if you want to contact us via Trust Management, we're happy to take those away and answer any questions that you may have. Thank you very much.
Good evening, everybody. My name is Neil Kemsley. I'm the Group Chief Finance and Estates Officer. I've been in that role since the 1st of June, but before then I was the Chief Financial Officer for University Hospitals Bristol and Western. I'm going to provide a summary of the accounts for the two organisations for 24-25, and I'll start with a bit of context relevant to both. I'm sure people who follow stories around the NHS in the news would have probably picked up that the NHS is extremely financially challenged and has been in recent years. And I would say in my career that spans about 35 years now, I've never known the context to be as challenging as it's been in the last 3 years post-pandemic. And so one example I can give of that is that our system, so Bristol, North Somerset, South Gloucestershire, and the healthcare organisations within are one of 11 systems around the country, 42 in total, that were able to set and deliver a balanced financial plan for the year in question. So the fact that 75% of systems and organisations are struggling to break even is, I'd say, indicative of the scale of the challenge. I do get some feedback, pushback, given the extent of the problems elsewhere. Why does our system, why do our trusts endeavour to achieve break-even? And I would highlight 3 points. So the first is the duty we have to the taxpayer. Secondly, by looking after our finances, we do stay in control of our own decision-making. And systems that have struggled have lost a lot of autonomy in terms of their own decision making. And then finally, I would say that there are some tangible financial rewards for achieving break-even. So as a result of achieving a balanced position last year, we secured an additional £17 million of revenue support and around £14 million in terms of capital. And the example I always use for what we did with that capital was the additional children's outpatient service in the education centre in the centre of Bristol, which enabled us to expand the footprint of children's ED, which made us a Bristol position to have a better winter in terms of the operational service. So in-year meaningful change into what we're able to provide. And the rest of the commentary on this slide, again, is a bit of context, some relevant to the new financial year. So last year we had a continuation of what we describe as uncapped financial support for elective surgery, so inpatient day surgery that's arranged on a planned basis, our first follow-up outpatient. Some other services that the NHS England and the government were very keen we continue to recover in terms of performance post-pandemic. So no limit on what we could provide, no financial limit on what we could provide. The last point here on this slide is we call it cost improvement plans or savings targets or efficiency targets. They're all the same thing really. So for UHBW, a target of 41 million in the year just ended, compared with 21 delivered in the previous year, and for MBT 29 million versus 18 million delivered. So you can see in setting the plan for 24/5, we set ourselves a very stretching target in terms of an uplift in the savings achieved in previous periods. I'm now going to go on to say a bit more about UHBW's financial performance and financial makeup. Thanks, Josh. So bottom line, around halfway down the table, I hope people can see from the back. The bottom line is we delivered a surplus of £43,000 at the end of the year. So the objective in NHS Finance is to land just the right side of break-even, and we use an analogy of it's like landing a jumbo jet on a postage stamp in terms of trying to end the year, as I say, just the right side. Against that £41 million worth of savings target, we achieved 32 million. So glass half full, I'd say that was 11 million up on the previous year, but there was a shortfall that made the new financial year a little more challenging. And we delivered a capital programme of £47 million, so slightly higher than our budget. But again, you're allowed to be flexible within the system, so one part can marginally overspend if another part of the system underspends on its capital budget. They can see a very significant level of spend on our capital programme. I'm going to say a bit more about that in a moment. The next table, so this is a summary of the income coming into UHBW. Rather than go through the same detail for MBT at the moment, I was just going to draw a couple of comparisons. But first of all, try and get people's heads around the overall financial scale of the organisation brought together. So it's, I'm going to round up to this year's figures, £1.4 billion in UHBW and 1.1 billion is the turnover for MBT. So £2.5 billion a year in terms of our revenue budget. So that equates to £7 million a day that we're spending, or between £3 and £4 million, so £3 million every 12 hours. I was trying to do a comparison with, I've gone to football clubs because it's, so Bristol Rovers annual turnover is equivalent to 1.5 days of running our trusts. Bristol City is 7 days running our trust, and if I went to a more a global brand, we are 3 times the size of Man United in terms of our annual turnover. The composition in terms of the income that we receive for treating patients through research and development, education and training is almost identical across the two trusts. One small point of difference would be the research and development income, which stands at around 38 million for UHBW and 15 million for MBT. The rest of the percentages, as I say, are almost identical. Next slide then shows an equivalent a depiction of our profile around expenditure. And again, I'm just going to draw out the differences between the two organisations. So staff costs in UHBW represent around 60% of our overall cost base, whereas for MBT it's 64%. And the main difference then in terms of non-pay is drug costs in UHBW of 188 million, so around 13%, and it's 8% and 78 million in MBT. And that difference really represents the specialty profile within UHBW compared with MBT. So the fact that drug expenditure will be higher in specialties like oncology, some of the cardiac services, and rheumatology would be the key drivers of that difference. My last slide on UHBW gives a bit of summary in terms of how we invested the £47 million. So typically across a range of estates, backlog maintenance, new medical equipment, replacement medical equipment, and some of the more interesting aspects of the spend in terms of transforming services are on the right-hand side. So a new linear accelerator, a new neurosurgery robot, and an expansion of our previous surgical specialty robot program. And again, to give a bit of context for UHBW, that £47 million last year is on top of around £300 million of capital investment over the previous 5 financial years. And we have £102 million worth of investment scheduled for 25-26. I move into MBT. And again, if I go to the overview slide, the headline again, 43,000 surplus in UHBW, 30,000 surplus in MBT. So both trusts land in a position as required. Again, I'll remind you of that context I set at the beginning, where 75% of trusts are unable to balance their books or can only do so with very significant levels of support. The fact that both organisations are able to land our position at break even in the context of a system that's been able to do the same for the last 3 financial years is noteworthy. And I will always make the point that whilst the finance department might take the credit for the quality of the accounts, delivering that financial performance is achieved across the whole organisation. So real collective endeavour to deliver that also alongside improvements in operational performance and the broader quality of our services. So MBT, the capital investment for the year, around £73 million, higher than the level for UHBW. And again, that's really about the surgical centre that Ingrid's mentioned, and Tim will cover in a bit more detail later on in our agenda. I haven't mentioned cash in both organisations, but for those who did see it, both ended with more cash in the bank at the end of the year than planned. So over 70 million in UHBW, 63 million in MBT. And again, it's important to note that because it's another indication of robust financial health, when again we can see across other parts of the NHS, organisations are beginning to struggle. I'm not going to do the 2 graphs for MBT because I tried to draw out the comparisons as we went along. But again, we've got a summary slide in terms of the capital investment for the year just ended. I will say a bit more about the Princess Alexandra Surgical Centre. So whilst it's built on the MBT site and it's being delivered through MBT's financial books, really important to recognise it as an asset for the whole of our system and the wider population we serve. The sources of money, £35 million, came from a national source, an additional allocation to the organisation And that was topped up by around 15 million. That's the number one priority in terms of how the system spent its capital. So fantastic resource available to support continued elective recovery post-pandemic. And then you've got a couple of other examples from MBT in terms of the surgical robot program and the 3D center. And finally, on this presentation, I look forward to 25-26. Finance directors do get accused of saying that this year's even more challenging than last year, and that is certainly the case. And again, we can hear the ripples across the NHS. Difference this year is that every system has set a balanced plan, but it's pretty much the same 3/4 of those systems have relied on deficit support funding to be able to be in that position. We continue to do it through our own resources. The information I'll use to try and show just how much more this year is compared to last, and again, the further uplift in terms of the savings target we've had to set. So on the circa 29 million delivered in MBT, 22 million delivered last year in MBT, looking at 40 million pounds as the target for this year, 32 up to 53 million, the equivalent for UHBW. So across the group, we need to increase our savings delivery from 55 million to 93 million. And that is a mammoth task and the number one challenge in terms of delivering this year's financial plan. Just one other thing, change of context, is I spoke earlier that there was no limit in terms of the funding we received based on the volumes of patients we treated through elective activity, whereas this year there is a cap in terms of how much work we can do, subject to the demand management program being agreed with our commissioners. The last bullet on here just re-emphasises the scale of the capital investment across the organisation. I did want to just close by thanking Duncan. We do enjoy really healthy relationship with our external auditors across the two trusts. I would like to thank my finance team for, say, the quality of the accounts, but my bigger thing is my appreciation of the across the organisation in terms of the commitment to the finance agenda, along with everything else we need to achieve. I'm going to close there, and Paula is going to come up and pick up on the group development.
Good evening, everybody. So for those who don't know me, my name's Paula Clark, and I had the privilege of being appointed as a Group Formation Officer to the new Bristol NHS group back in June, but before that I have been a long-standing executive at University Hospitals, Bristol and Weston. And I have to say, having worked in the area for over 9 years now, I think we can be rightly proud of some of the strides we've made in collaborating across acute organisations. So firstly coming together across Bristol and Weston, and now coming ever closer together across the Bristol city itself as two very large organisations. So we are really grasping, if you like, the focus of the NHS and its core mission, to deliver outstanding care for every patient based on need and not means, and that is our fundamental role. So what we want to do this evening is take an opportunity to look in a bit more depth and to look back over the year. That's what we're here for, but also to take a bit of a look forwards as well into where we are now partway through 25-26. When it unveiled its 10-year plan earlier this year, the government did say the NHS needs to change. And what we want to be is right at the forefront of that change. We don't want to be directed to change, we want to be leading that change, and doing that with our communities, our patients and our staff. So who are we as Bristol NHS Group? Well, Ingrid's already referenced, we can declare we are high-performing organisations, as referenced in the National League tables. and we have that strong record of collaborating. We have histories of working really closely together to deliver the best care we can. And we also deliver world-leading research and teaching. So that kind of tripartite delivery means that we can give an offer to the communities and the populations across Bristol, North Somerset and South Gloss that gives us all access to services that don't exist in every area. We provide healthcare to over 1.5 million people across Bristol, Weston and the wider Southwest. And we have a combined turnover. Neil's already given us a lot of the detail in the figures, but over 2 billion. And you can see the scale as well in the number of people who were privileged to come and work for us every day, over 28,000 members of staff. And they deliver services at 13 hospital sites. Community sites as well are also part of our locations. And it's quite unbelievable sometimes to know that we provide over 200 clinical services, and those go right from the very start of life, from fetal medicine and groundbreaking interventions in fetal and paediatric care to care of the elderly. And we are also, as I said, proud to deliver a very high number of specialist services. So up in Southmead, we're the Adult Trauma Centre for the whole of the Southwest. The Children's Hospital is the Paediatric Major Trauma Centre. We provide neurosciences, dental care, ophthalmology, burns, cardiology, sexual health services, all as specialist services, and that doesn't cover all of them by any means. So as I said, that access that we have to a really wide and diverse range of services does set us up as a very specialist group of hospitals, but very grounded in the care that we provide to our local communities as well. So we first announced our intent to work even closer together. Back in December 23, we said we want to form a group, and we embarked on a journey to help us identify exactly, what shape and form that should take. And I think, just 15 months on, actually, in April 2025, we formally became Bristol NHS Group. So we came together around that joint clinical services strategy vision. And that's a really important part of why we formed a group. It was all in the service of delivering better clinical services to local people, local populations. And that vision is to deliver seamless, high quality, equitable and sustainable healthcare. Not easy in this world and with the financial challenges that Neil has mentioned, to deliver sustainable care. And we'd want to do that for people across BNSSG and the wider Southwest for a very long time to come. And as Bristol NHS Group, we have set ourselves 5 really ambitious priorities to help us do that, and really focus on improving the lives and the health care of the communities we serve. So those priorities are delivering outstanding care for everybody who needs it. That's at the heart of what we're about. It's also about ensuring that our people can thrive and excel, that they've got fulfilling careers, because we will never deliver outstanding and compassionate care unless we have people who work for us who feel they've got fulfilling careers, they're respected and supported in the roles they do, because they're not easy roles. We also want to get the most out of our shared resources for the communities we serve. That's our duty, to use every single public pound to best effect. And we want to be able to continue to excel, to invest in groundbreaking innovation, research and development. We want to keep at that cutting edge of care, be ready to deliver the new thing, and take on board what we can learn from across the world about new interventions. And we know we can't do any of that without working with our partners as one team. And increasingly we are able to do that, not just as one team, but as one acute voice in working with partners. Sounds very simple, but allows people to navigate sometimes the many boundaries we don't see by working internally much more easily. And everything we have done and everything that we continue to do, we test against what we call our shared purpose, our 4Ps. And that's what difference is this genuinely making, this decision, this action for our patients, our people, for our populations, and for the public purse. So that is our test every day. And we've made significant progress even since forming the group formally in April. We now do have a single executive team, which is why we are all referring to ourselves as group executives. So we are responsible across both MBT and UHBW. We also have alongside that really strong local trust management teams looking after the operational delivery of services and led by our two hospital managing directors. And we focus on that, delivering the best of both organisations. It's not about dominance, it's about taking the very best of both. Our direction, is totally aligned with national policy. We formed our group almost exactly at the same time as the 10-year plan came out. So we believe that, Fit for the Future was launched, and we believe we have set ourselves up to be fit for the future, to be able to sustain that vision for high quality, equitable and sustainable care into the future. And the three big shifts in that 10-year plan, you'll have heard them, on the news, in some of the everyday kind of conversations: hospital to community, sickness to prevention, and moving closer to digital, away from analogue. And three very simple shifts to describe, but three quite complex shifts to achieve. And we believe that by working together, we can much better do that. And we're already doing quite a lot of it. We've expanded our care beyond hospital walls. Together we deliver and collaborate with our partners in the community to deliver NHS at home, app-based self-monitoring tools, for example, for patients in cardiology or respiratory, so people can manage their care, feel confident to manage their care safely at home, along with those who care for them. We focus on prevention and health equity, so a long-standing screening programme. All right, my liver, I haven't got the Bristol accent, so it doesn't sound quite the same. And that's given life-saving screenings to thousands and thousands of people outside of our hospitals, right in their local communities. And MBT have been doing some really groundbreaking work to prevent interpersonal violence, visiting schools, working with community organisations, really playing their part as an anchor organisation. And we have a growing national reputation in AI and robotics and in smart tech. And that's where we want to keep at that forefront of the digital and the tech agenda. In terms of combining our expertise and what we've actually been able to achieve over the last year, we've got a vision as part of our surgical strategy in the group to really scale up robotic surgery. It's something that we already do and have invested in, and over the last year we have delivered over 9,000 robotic surgical interventions, and that's really helped contribute to an improvement in our performance. So cutting into those long waiting lists and making a significant difference for complications in surgery, for people needing to be readmitted, and indeed for our surgeons and our theatre staff, actually, who often suffer musculoskeletal problems because of the long and intense surgeries they're involved in. So robotic surgery, good for everybody. We've talked about the Princess Royal Surgical Centre, and Tim Whittleston's going to give us more detail on that. That's also something that we're very proud of over the last year. And we have opened 2 community diagnostic centres across the group, which unbelievably have delivered 70,000 appointments so far over the last year. We've got one of those in Bristol, and we have one in Weston, and that's really allowed us to significantly improve our performance in diagnostics. 99% of people now have their diagnostic tests in 6 weeks or less at MBT, and it's almost 83% at UHBW. So, strong performance, but you can see there a bit of a difference. So how, working together, can we make sure that we make that even better across both organisations for the whole of the population? And the patient feedback who have used those CDCs you know, really important, has been incredibly positive. Easy locations, free parking, you know, things have to be easy if you're going to access care. We've also made progress on a real focus nationally on patient safety, Martha's Rule, and you definitely have heard about that. And that's really about empowering patients and families to have their voice genuinely heard. So families or patients can request an urgent review of their condition, the patient's condition, if they don't think that we are adequately addressing their concerns. We implemented that first in our children's hospital, the Bristol Royal Hospital for Children, in January 25. We rolled it out across 15 wards later in the year, and then we've gone live now fully across MBT, and we're rolling it out across UHBW by the end of the year. So, lots happening over the last year, and if we start to look a little bit forward now, we are developing our group model. We're starting to look at the 10-year plan and what that means. And we're really focusing in on some of the successes around our joint clinical strategy. And this strategy is led very much by our clinical staff. So we've put in place our very first group clinical service and cardiac services, which means we now have a single leadership team running all of the cardiac services across both organisations. So that really helps us make sure that people get the same experience, whether it's at Southmead, Bristol Heart Institute or Weston. That won't happen overnight, but the goal of that leadership team is to achieve that. Ingrid has referred to the community participation group. We'll be moving to put in place more group clinical services and aligning how we work together. And one of the things that we've heard from those teams is very much we can do things better. We feel as if we're one team, but actually in continuing to run and operate as two separate trusts, two separate legal entities, it's making it really difficult. We've got different approval processes, different digital systems, different policies and procedures, which we can address to a degree as a group, but actually we're required to report legally as two separate organisations. We've got to change that, and that's why we're proposing to merge. We haven't made any decisions yet. We're exploring that, and we'll continue to explore that in depth. But we do believe that that will allow us to reduce duplication, get better value for every pound we have, and fundamentally to make some of those shifts that the 10-year plan requires us to do, and patients and populations are demanding that we do into the future. So we've got a really exciting agenda ahead, but we've achieved a lot. I'm going to hand over now to Glyn and back to Neil, who are going to give us a bit more in detail about each of the individual organisations. Thank you.
Hi everyone, my name's Glyn Howells. I'm the Hospital Managing Director up at North Bristol NHS Trust. So 2024-25 was a year of delivery and innovation for us, but also of resilience. We had quite a bit of headwind with some of the industrial action from the resident doctors as we tried to eat into that the backlog in elective care that had built up during the pandemic. Next slide, please. Thanks. MBT's commitment to putting patients first isn't just a slogan. Everything we do and everything when we are organised completely around putting the patient at the heart of what we do. So it covers not only the place that we're heading, our aim, and all of our trust objectives aligned to that, and our improvement priorities, and all of the improvement projects that our staff are working on are all geared towards putting that patient put at the heart of everything we do. Next slide. We've continued to act and learn to what matters most to patients and to carers. We had over 109,000 people sharing patient feedback through the Friends and Family Test, with 92.5% of people voting positively as for their experience. We've deepened our engagement with over 200 real-time patient and carer conversations, co-designing the delivering significant news charter to support compassionate communication during difficult conversations. We launched our first mental health strategy. We're now at a position where well over a third of patients that come in for physical health matters have some ongoing mental health concerns as well that we need to work with them on. So having a mental health strategy as an acute trust is really important to us. And this year we'll be building on this by embedding shared decision making and rolling out digital e-consent, which means that patients get more control and clarity around their care journey at NBT. Slide. We've made real progress in improving access to care. During the year, we cleared all patients waiting over 65 weeks and now have fewer than 1% of patients waiting more than 52 weeks. We're down to about 0.5% of patients now waiting over 52 weeks, and we'll clear that this year. Our diagnostic performance was amongst the best nationally, with 99% of patients being seen within the 6-week constitutional standard, which we're really pleased about. Our cancer faster diagnosis performance, which is getting all cancer diagnoses turned around within 28 days, is consistently above 83%. Not quite where we want it to be, but it's a marked improvement year on year. The new Community Diagnostic Centre at Crib Causeway has been a game changer for us in allowing us to sort of just move some of the high volume tests off the acute sites so that the acute sites can be focused on the patients that are in our hospital and need the access to diagnostics there. And on safety, we've embedded national frameworks, expanding human factors training, and have launched a joint mortality improvement programme with UHBW as part of our commitments to delivering care that is not only timely but safe and compassionate. So we know that health inequalities persist, and we're committing to improvements. By year end, 82% of our patient attendances recorded patient ethnicity, and this is absolutely key to us making sure that we are providing equity of access and equity of outcomes from the services that we provide. We've improved access to cardiology services in deprived communities, expanded support for people with learning disabilities and those experiencing homelessness, and we've worked to reduce the barriers for Gypsy, Roma and traveller groups. We had a presentation at one of our board meetings about what it is like to receive care from us as a member of the Gypsy, Roma travelling community, and it is eye-wateringly bad. And it's important we stare it in the eye and make commitments to improve it. But it's really, really important we listen to and we learn from the communities that we are not giving as good a service as they deserve. Next slide. Innovation. Innovation and research are absolutely central to our mission. In 24-25, we secured over £1.5 million of NIHR research capability funding, which is the 3rd highest in England. During the year, we also opened 106 new studies, which is a huge amount, covering over £9 million worth of grant income. There is real evidence that shows that where you have curious staff that are seeking to improve care, patients get better outcomes. So this isn't some vanity project we're doing because we want to see our name up in lights. Patients get better care as a result of the research and innovation that we show there. We continue to lead in surgical innovation with nearly 9,000 robotic procedures completed across urology, colorectal and gynecology. In one weekend alone, our gynae services, working with one robot, did 25 robotic operations, with 16 of those patients going home on the same day that they had their surgery. We couldn't do that without robotic surgery, and it's a record achievement in the Southwest. We also became the first NHS trust to sign the sustainability in research order. So we have got to make healthcare more sustainable for the sake of our children and the planet. Next slide. The year wasn't without challenges. We had repeated sets of industrial action which disrupted our elective recovery programme and cancer services, requiring lots of resets and replanning. Cancer pathways remained under pressure, and the 62-day performance averaged around 59%, which is an improvement on the prior year, but it's still some way away from constitutional standards and the standards that we want to provide to our patients. Emergency care faced real sustained demand, with 4-hour performance at only 63%, and rising number of 12-hour trolley breaches, due largely to us not being able to discharge patients that no longer required our care, and that causing bed pressure through the hospital and causing ambulances to wait at the front door. Across the system, each day we have around 200 patients in our hospital that do not require acute levels of care anymore, but be working with our system partners to try and get the flow out into the community, so that those patients are receiving the care they need in the right place is proving a continued challenge, and those challenges roll into this year too. These challenges have tested our resilience, but they've also strengthened our commitment to collaborative system-wide problems. We can't solve this having a few steps. We have to solve it working with other health partners, with our local authorities and the third sector. Our people are the absolute driving force of everything that we do. In 24-25, we made real meaningful progress in creating a workplace where colleagues feel valued, supported, and empowered to thrive. So how do we know that? We know that because we've got fewer people leaving. Our turnover rate is down to 12.3%, which is the best we've seen in recent years. 92% of people had an appraisal in that year, and these figures reflect a culture of accountability and growth. The NHS survey results showed that 86% of the responses were the same or better than the national average. And what we're really proud about, for the second year in a row, we scored in the Southwest the highest proportion of staff that said that they would recommend us as a place to work. And that really makes us feel we're doing something right. There's always things to learn and improve on, but we are doing some things well. We continue to build a culture of safety and respect. One of the things that came back through the staff survey is that we are seeing violence against staff and racism against staff and misogyny against staff rising, and so we have to do things about that. And we have launched the We Do Not Accept campaign, which protects staff and patients from violence, aggression and abuse. We've got more work to do on that area, and more recently we have just launched our anti-racism pledge, which recognises that people from a global majority do not get the same opportunities within the hospital at the moment, and we need to do something about that. The first thing to do is to call it out and accept that that is the reality, that the lived experience that our staff are having, and work now to improve and say, right, what does good look like and how do we get there? But hold that mirror up and stare it and look it in the eye and say, this is what is happening, this is what is happening. For some of our staff, we need to do better. Our wellbeing offer to staff has been expanded to include targeted menopause support, financial wellbeing, and new inclusivity campaigns to make sure that all colleagues feel safe, supported, and able to bring their whole selves to work. Finally, next one. Finally, just a huge thank you. Our staff is what makes the difference to allow us to be able to provide the great care that we do. I'm proud to be the director here, and I'll now hand over to Neil, who's covering because Stu Walker, the managing director at UHBW, is on annual leave this week, so you get another burst of Neil.
What more could you ask for? I'm not going to test you on the earlier presentation. You'll be relieved to hear. As Clint says, Stu Walker, the hospital managing director for UHBW, would have provided this update. Stu's on holiday, so I will cover the section. At UHBW, we regard 24-25 as a year of new beginnings, and we launched our new trust identity, Wholehearted Care. Really important to acknowledge that this was developed with input from literally thousands of staff across the organisation. And I would like to credit Emma Moody, our Director of Communications, in terms of the work she did in leading this programme. So Wholehearted Care is our ethos in making sure we provide the same high quality level of care to our colleagues and the community as we do for our patients and families. In the year, we also launched our experience of care and digital strategies to accompany the people and estate strategies that have gone before. So through the year, we delivered and celebrated many successes, but also, as Glenn has described, a very challenging backdrop in terms of emergency care pressures, industrial action. So taking a look back through the year, so we set Under the auspices of Full-Hearted Care, we set a new vision, mission and purpose for the Trust. So the vision to become the trust that pioneers new standards for patients, staff and communities. The mission to advance the health and well-being of our communities. And the shared purpose that we exist to make a difference that matters to the lives we touch. To enable the achievement of this vision, the Trust Board has approved 6 strategic priorities to transform services for the patient, for the benefit of patients and colleagues. Given the fact that one of those priorities, which is the use of resources, I would have covered earlier on, I'm now going to talk through the other 5. So firstly, the experience of care. This is largely driven through the My Hospitals Know and Understand Me programme. This has been co-designed with patients, communities and staff. The strategy sets out the vision of providing patient-centred, compassionate and inclusive care every time for everyone at all stages of their life. We've been making real progress during the course of the year in terms of our inpatient and outpatient monthly services, monthly surveys, and as Glyn described, I'm really pleased with ratings in terms of good or very good services that stand at 92% for inpatients and 96% for outpatients. Just over 90% of people who've used our maternity services have also rated those services as good or better. And we've been focusing on better communication in UHBW settings, which includes providing an adoption of the What Matters to You method to ensure we are taking a person-centred approach to conversations. This is really about tuning in with individuals in terms of their direct and recent experience and making sure that we are learning from individuals. A couple of more tangible examples of experience of care are the sanctuary garden sessions that we've set up for people living with dementia. We're now approaching the 2nd year of that garden in Bristol and the 1st anniversary of the garden in Weston. The second priority area is around patient safety. So last year we launched the UHBW clinical strategy with the following goals: to work in partnership to strengthen our clinical services, to design our future clinical services with our communities, increasing equity and improving the health of our local and regional population, to drive innovation and be bold about our ambition to pioneer new standards, and to deliver the benefits of the healthy Western vision to be a strong and dynamic hospital at the heart of the community. We've also introduced new systems such as the Careflow medicine management system. So this is an e-prescribing technology. The system will help in minimising medication errors, improving patient safety, and improving both outcomes and operational effectiveness. The deployment of that system in UHBW is literally following in the next couple of weeks at MBT. So for us, this is another example of us making immediate progress in the context of the 10-year shift and the shift from analogue to digital that Paula described. And we have other examples. So we have the deteriorating patient program with a focus on identifying patients with sepsis or at risk for sepsis. And again, in Western, we have an award-nominated integration project that's looking to transform the way frailty care is integrated across primary, community, and secondary care services. Third area of priority is around timely care. And again, Glyn's described the context in terms of the challenging winter. I'll just draw out a few of the statistics that Glyn also provided. So despite the busyness, we had the best 4-hour performance target we've been able to achieve since COVID. There's still very significant room for improvement, but we're steps in the right direction. And the same is true in terms of the 10% year-on-year improvement in terms of ambulance handover delays. Like MBT, by the end of 24-25, no patients were waiting over 65 weeks from referral to treatment. We have made progress in terms of the overachievement of the faster diagnostic standard in cancer services. And although we've made progress in terms of diagnostic testing, improving from around 79% to 85%, it's quite a distinction in performance between UHBW and MBT, there's certainly an area of progress there. From an efficiency and productivity perspective, a 5% improvement in the amount of time it takes from a patient commencing their anaesthetic to leaving theatre. And in terms of trying to reduce patients who do not attend outpatient through the utilisation of our doctor-doctor digital letters, we're now up to 1 million letters have been sent out. That's reduced do not attends by 1.5%. I think it's saved around 10,000 outpatient appointments, or enabled us to use those alternatively, and has saved, as well as environmental savings, has saved around £2.1 million. Next area, you can see this follows a very similar format to what Glyn described, is around our people. And again, I'm just going to pick out a couple of examples of work underway. In terms of the culture of the organisation, our focus in terms of creating UHBW to be an inclusive place to work and eliminate disparities in colleagues' experience. And as Glyn acknowledged, I think both organisations do recognise that there's much more progress is required. So we have made our statement in terms of being a pro-equity organisation and to stand against all forms of discrimination. But as I've mentioned, we know that we need to go from some very significant staff engagement exercise to tangible action that people will feel a difference. I have been asked to draw attention to the diversity, equity and inclusion section of the UHBW website, and we very much would welcome feedback through the comms team in terms of people's thoughts in terms of that being appropriate steps towards our anti-racism statement. We've developed a range of pathways across nursing, allied healthcare professionals, pharmacy, admin and clerical, with career pathway and programs of work in place for all groups of staff. And I also wanted to draw attention to the Full-Hearted Care Awards that we enjoyed back in May. I think around 900 nominations across the organisation, and a really fantastic evening celebrating team and personal success. And I know the equivalent MBT event is just a couple of weeks away. But also on this slide, we've acknowledged 4 individuals that have been recognised both nationally and internationally for their services to healthcare, so did want to highlight that. Finally, we have our 5th workstream around innovation and improvement. We have the same patient-first methodology that Glyn's described in North Bristol. We've been training and coaching teams in continuous improvement techniques. So far, 18 teams have undertaken that programme. 540 local improvement ideas have been put forward, and 60% of those have already been implemented. And again, really important if people engage in those programs that they can see the results. Taking this to a much more personal level, where all about the services that we provide. I will speak about Freddie. Freddie, age 4, was the first patient in the UK to benefit from our new extracorporeal membrane oxygenation, so the ECMO 2 that's provided at the Bristol Hospital for Children. Really pleased to say that this is a new service, new across the whole of the UK. Freddie recovering really well. Freddie and his family have been fundraising to put money back into the unit and the paediatric intensive care unit that cared for him. And in Western, the physiotherapy team in subacute stroke rehab has introduced new techniques of neuromuscular and functional electric stimulation. Again, real impact in terms of the improved outcome for patients there. And then finally, if I just talk briefly around the research angle. So we're very proud to be hosts for 3 National Institute for Healthcare Research infrastructures. 124 new studies started in 24/5, of which 38 were commercial, very significant income streams for both organisations. And finally, under research and development, we were the first site in England to launch the Generation Study, sponsored by Genomics England in partnership with NHS England. And already 900 women have joined that study at St Michael's Hospital, and leading to technology and research around 240 treatable conditions that can now be identified in babies, and proactive care arranged from the start. So hopefully the highlights I've shared bring to life some of the successes over the last year. As Finn did, on behalf of the board, I want to express my thanks to colleagues across the entirety of UHBW. And now I'm going to stop, and a film is going to be shown of another really critical group and of one of colleagues across our organisation, and that's the volunteers that support both UHBW and MDT.
My favourite thing about volunteering is just to see the smiles on people's faces, and actually when you speak to a parent and they say you've actually made their day because actually they've spoken to someone, and it's not talking about medical stuff, it's just general chit chat, and it's just nice and breaks their day up, and to go home with that thinking you've helped somebody during the day.
My favourite part of volunteering is working with a group of like-minded volunteers. We're like one big happy family. You're doing good for other people as well as making yourself feel good.
I feel I can support not only the staff but the patients in our hospital who might need that little bit more assistance when they come into the hospital. So whether that's the volunteers who help people get to their appointments because they're not sure how to navigate the hospital, or in my role as lunchtime volunteer where those people need a little bit more assistance.
My favourite thing about volunteering, I think there are two favourite things. One is that I get to work with a great team. We know each other well. We have a lot of fun, and I look forward to Monday mornings. And the second thing is that what we're doing here for 4.5 hours on Monday morning is just helping to make things better. And that's a great way to spend your time.
My favourite part about volunteering so far has been making a difference in someone else's day, but also expanding my understanding of a healthcare setting. I would without doubt definitely recommend this position to someone else, as it's not only rewarding but it's helped me grow as a person, has allowed me to meet some of the most amazing people, develop new skills, and also give back something to the community, no matter how small.
I'm a member of the belly dancing group and the ukulele group, and I always have a little bit of fun with them at the end, and I do a little dance to them, and I said I never thought I'd be able to dance again, and so we always end up laughing. Yeah. I also have a foot that doesn't work quite properly, and I've been exercising it by flipping all the hospital bins as I go through the different wards, and that's what I do when I leave their rooms, and that's what makes them laugh as well. Yeah. And I love meeting people and sharing experiences with them, and they love telling me about their lifestyles and what they're up to, and hopefully I always leave them in a happier state than I found them, you know.
Hi everyone. So I'm Ben. I'm here as the lead governor to give you the update from the governors and the membership perspective at UHBW. So this is my second term of office as a governor. I've been doing it for 3 years now. The other governors elected me to be their lead governor in November last year. Admittedly, at the time, all the governors were stuck in interestingly deliberating over whether to elect me. But I was having a taste of business travel on my way to India, so not the best timing. But anyway, who are governors and what do we do? So we do have a diagram that should help explain, but essentially we are elected by trust membership, so that consists of public and staff to represent them and their values. So since 2022, we have had a wider responsibility to the population of our local systems as well that our membership covers. The governors are responsible for a number of statutory duties. The most important one of them is about seeking assurances. We are there to ensure the board carries out its duties effectively, especially taking the needs and interests of our patients, people, and the wider population into account in its decisions, as well as Paul was mentioned, the demands on the public purse. So I think that's all 4 P's covered there. And we do this by asking questions to the board of directors through a variety of forums. So we have our Council of Governors meetings, and those meet 4 times a year, and they're open to the public to attend and observe, and hopefully we might see some of you. We have regular meetings with our non-executive directors and focus groups that we do deep dives into quality, strategy in our membership, and we have a governance log for questions that need a bit more research to give us that definitive answer, and these are published with the Council of Governors papers. We're also required to do a couple of other things. So we appoint and agree the remuneration for the chair and the non-exec directors. This year we have had to do that in collaboration with MBT, so we've agreed a joint approach to doing it together. We approve the appointment of the chief executive as recommended, so I see Maria has snuck in, and we're good to welcome her to the post this year. We received the annual report and accounts, which is exactly what we are doing tonight. And we approve significant transactions and mergers and acquisitions and any constitutional changes, and ensuring that we are compliant with the Constitution and the broader regulatory framework. But that's the meaty stuff. There are lots of other things that we do as well. So on top of these statutory duty items, we have opportunities to get involved in lots of other areas of significant interest. For example, we get taken on site tours and take part in patient-led assessments of the care environment. So last week we were at the Bristol Haematology and Oncology Centre on St Michael's Hill. We also sit as representatives on certain steering or oversight groups, such as our Health Equity Delivery Group and the New Community Participation Group. And we come along to and attend our health engagement events, including the Health Matters series. We also get regular training and development from the corporate governance team to support us with fulfilling our duties. And that membership and corporate governance team send out monthly membership newsletters to our members with regular updates. So over the last year, we've spent a lot of time, as you can imagine, discussing bringing together of UHBW with North Bristol NHS Trust to form Bristol NHS Group. We've been heavily involved in receiving and feeding back on the joint clinical strategy because it matters to our patients, and the group benefits case as it went to before board as well. We've looked at our trust constitution to make sure that we're operating as a group of trusts more efficiently, and we've appointed non-executive directors and appointed Maria and Ingrid, and we have, although not the financial year we're talking about, we have now appointed group non-executive directors as well, and we have one more position there to fill. And we've also heard from Integrated Care Board about the wider health system and how particularly lengthy discussions with our board members on topics of interest. I think no criteria to reside is one that comes up very regularly. So if we look at our membership, these are as of the start of this month, we have about 3,604 public members and 17,005 staff members. We have about 60,000 of those with an email address, and so those are the people who receive the monthly newsletter from the Trust. And the membership has remained broadly representative of the people that we serve. But I think we all recognise we want to grow our membership. And this year, we saw the launch of our new membership strategy, copies of which are available at the back to help support this aim. And then finally, what are our goals for the coming year? So engaging with our membership is going to be more important than ever, as the Council of Governors is going to focus on 5 key areas. We're going to explore the merger that has been alluded to, with bringing our group hospitals into a single organisation to better realise the benefits of the joint clinical strategy. We're going to continue monitoring patient discharges and waiting lists, keep on top of no criteria to reside and those accident and emergency lists. We're going to achieve the objectives that we set out in our membership strategy and engage with our members and our communities to strengthen government knowledges and our networks. And finally, we're going to be looking and observing the implications of the 10-year plan for the NHS in England. So we'll be keeping our members updated on these key areas through the newsletters and future drop-in events over the course of the next year. If you're not already a member of UHBW, we strongly encourage you to become a member and ensure that we have your up-to-date contact information. And finally, on behalf of all the governors in the room and those with us as well, I just want to say thank you for joining us today. We'll keep it brief. Thank you.
Big step. So my name's Tim. I'm a doctor. I'm the Chief Medical Officer and Innovation Officer for the Bristol NHS group. I recognise quite a few people, but not everybody. I've been a surgeon in Bristol for over 30 years, and I think I can honestly say I've probably put stitches in bladders in Southmead Hospital, the BRI, St Michael's Hospital, the Cotswold Unit, and Westbourne General Hospital. So there isn't many operating theatres that I haven't been in around our new group. I've been given a fantastic task today to try and wrap things up as quickly as possible. We've been sat here a long time to talk about the Princess Royal Bristol Surgical Centre. It's been referenced multiple times, so you probably have heard most of what I'm going to say in the last few presentations. We talk a lot about waiting lists. They're on the news. You hear it when you turn your radio on, you hear it in our reports, and actually looking around this room, there are quite a few people who are on waiting lists, statistically speaking, and we often just use it as a throwaway term, don't we? But what's a waiting list? A waiting list is a list of people, and those people are in pain, or they're housebound, or they're really worried. Their families are really confused about what happens next. And I've been on a waiting list. As I say, most of you will have been on a waiting list. The worst thing is you don't know when that waiting list comes to an end. And you know that what you're waiting for is not that pleasant. It's not like waiting for an Oasis ticket at the end of the Ticketmaster telephone call. At the end of it is a pretty major, potentially life-changing procedure. Waiting lists are really, really bad. And they have grown relentlessly throughout the COVID years, and they will, if we don't do something different, it'll be practically impossible for us to recover them. If you combine that with our rising population, that's a good thing for Bristol, North Somerset, South Gloucestershire, a vibrant area. People want to come and live here. People are living longer here. Means our population's rising. That's just adding more people to that waiting list. And you'll appreciate that managing a waiting list in our current format of healthcare is really tricky because we can plan, we can build operating theatres and wards, but of course things like winter come along, flu epidemics come along, major incidents come along. That fills our hospital with emergency cases. That means we can't be as productive as we want to be, and therefore we have to think about doing things differently. So we had a bit of a vision session many years ago now, and we thought about what we can do to try to tackle this. We can work harder, we can work at weekends, we can bolt on some operating theatres, we can put some beds in the car park, we can build tents, we can do whatever you like to do. And we have tried it, we've tried it over and over again. And it helps a bit, but it doesn't solve the problem. So we had to be a bit more visionary about it this time. And I think there is somebody in the room who I will name check. Caroline, where are you? Caroline, really a visionary woman there who said, don't do things in the car park, don't do things in a tent, build something proper. Why don't you build yourself, a dedicated surgical hub, somewhere which is separate from the comings and goings of a very busy hospital, something which is big enough to cope for the whole of our community, for Bristol, North Somerset, South Gloucestershire, patients from Western and patients from without our region who can come here. It'll last a long, long, long time. It'll be built to very high standards, be very efficient, be very productive, and it'll be the best possible facility that we can provide, the best possible that you can get anywhere in the world. I was going to show a video, but I don't think there's really time to show a video. And I think for those of you who've got children, you'll love playing Lego. So 2 things you know about Lego. It's fantastically fun. It's sometimes quite quick to build and very efficient building. And it's also quite expensive. So that video that I was about to show you is basically a £50 million Lego toy, which we won't do. Oh, we will do. Now, just a little bit about how it works. Because some people ask me quite a lot about this. They say, well, you built something on the Southmead site. It's just a Southmead asset, isn't it? That's great. Well, that's not true at all. Because what that building is, that's a building for the whole of our community. It's an elective centre for the whole of BNSSG and beyond. And the way that works is that we're able to displace, we're able to take out some operations from, say, Southmead Hospital, from the Bristol Royal Infirmary, and we're able to do them in this facility. That frees up space for appropriate procedures in the BRI, in Southmead Hospital, in St Michael's Hospital, and in the Cotswolds unit. So it might appear on the surface that this is about hips and knee replacements, and that's what you'll hear a lot about. But in actual fact, this is multidisciplinary. This is allowing us to tackle waiting lists, whether you've got a bowel problem, a head problem, as well as musculoskeletal problems and gynecological problems. And this is an amazing, it might not sound that amazing, but it tell you from a surgical point of view, this will deliver over 6,500 extra operations a year. That's on top of what we're already doing. And it's already working. And I don't know, Nick, how many have we done? We've done nearly 100 cases this week so far. It's working. It's actually delivered. I can't believe I'm saying it, delivered on time and on budget. That is true, isn't it? I'm not making it on time and on budget. That's quite astonishing. So I always say that, you know, a building, well, I'm going to touch the wall. A building's hard and cold, isn't it? And it's people that are soft and warm. So it doesn't matter what you build. We could have built anything, but actually a hospital is about the people within it. And as well as building, we've actually recruited, we've now employed 160 new people to help us to staff this. Some of these, we're not putting all the new people into one place. We're taking some people out of the BRI, some people out of Southmead Hospital. We're giving them the opportunity to work in the Princess Royal Centre, and we are complementing those with new staff. There's a lot of training and onboarding that's still going on. That takes a long time for teams to work together productively in a new building. And it allows our specialists to rotate around the various hospitals in the group so that they're able to enjoy treating their patients here. So it really is a symbol of something substantial happening to the Bristol NHS group. You've heard about the investments. Just to make the point, quite a lot of the money comes from the Treasury, from the Recovery Fund, which the government launched post-COVID, and some of it is local decision makers, maybe some people who are actually sat in this room who helped to make this decision, who have directed some of the very precious money that our local system has. So it has buy-in nationally, it has buy-in locally, and it has buy-in clinically. It's a fantastic facility. If you haven't seen it, I'm sure you've seen it, walked past it, driven past it, been on a bus. In the nicest possible way. I hope you don't have to go into it, but if you do, I can assure you it is a really phenomenal facility. It's net zero, and it's built to these BREEAM standards, which means it is the very best possible exemplar of building for sustainability. It's about patients. I'll come back to the waiting list. What does it really mean? It means faster access to surgery. It means that we can now see not only those waiting lists stabilising, we can see those waiting lists coming down. And again, coming back to us, me, you, people who are waiting for an operation, that's fantastic because now
our clinicians can actually predict with a high degree of certainty when your operation will be. Okay, now it's not tomorrow. It might not be next week. It might not be next month, although those numbers are coming down. But we can tell you almost with a high degree of certainty when it's going to be. That means you can get your head around it. You can start to plan for it. Your families can start to make the necessary arrangements. And again, just look at that. The facilities are really the best in class. They are really phenomenal. That's an actual picture that we took the other day. If you can't see it, that's not a jacuzzi. That's actually a garden at the back. We haven't gone that far. We haven't wasted public money. So this is more than a building. It's a promise kept. It's a promise to our community. It's a promise to our patients that we would do something about it. We'd be ambitious and we'd put some money where our mouth is. And a lot of people would spend a lot of time planning, resourcing, and worrying about it. There's a lot of worry that goes on when you're building something like this. It provides fast, fair, and better care. And it really is, a phenomenal asset for BNSSG, our local community, and also for our wider region, where we know that we add value to our patients. So it really is a time for celebration. And if you haven't seen it, I would urge you to go and have a look at it. Thank you. Ingrid.
So I think our group chief executive is with us, Maria. Maria has been in London today because she had a really important meeting with none other than Wes Streeting and was delayed getting back from London, but she's here now. Maria, do you want to come up so people can see you and maybe hear from you for a moment? We are running a bit late, but you've been so patient in listening, and I really want to give the floor to yourselves for any questions or points that you would like to raise with us. Could I just ask board members to stand up so that people know who you are? There are some of them in the room. So you've heard from some of our executive directors as well. The people to this side and Sarah there are non-executive directors that you heard about from Ben earlier. We have had a couple of heads up of questions, one about merger and how we're going to consult on that, and the other one to do with public transport. I don't know if those people are in the room. Yeah? With transport.
Good evening. My name's Ken Booth. I was a governor here about 10 years ago, and I remember discussions then about accessing the BRI by public transport. And we're still wanting a solution for that. I mean, I've been in Bristol now for nearly 50 years, and we still don't have a public service passing the BRI. It just beggars belief. I live in Clifton now, and we have no less than 3 buses plying the same route into the city centre. That's the number 8, number 5, and very recently a new route, the 77. Now, why can't one of those buses pass by the BRI? What is the problem? I put a suggestion to my local councillor, Paula O'Rourke. I wrote to Carl Denier, and they approached First Group, and this is what First Group had to say. Unfortunately, due to the added time and resource that it takes for a limited number of passengers, it would not be viable for us to adhere to the constituents' request. Well, actually the 77 not only serves passengers that wanted to go to BRI, it serves anybody on the route from Black Boy Hill through the centre and anybody from the top of Muller Road to the city centre. So it's not a question of the paucity of passengers. Second comment they made is that Malden Street is a no-go zone for buses. I wonder why that is. Is it because there's too much traffic and people can't get to the hospital any other way? I mean, it really is a scandal that this is allowed to go on. But, First Group, they seem to be only concerned about their organisational difficulties, not the actual passengers that want to get here. I mean, North Bristol have the 505 service. Again, a service that is used by the general public to get about the city as well as to get to and from Southmead.
So I think we've understood the point.
Thank you.
Really important to get public access with ease to services. Neil, I think you were able to respond to that.
Thank you. Thank you for the question and for giving a heads up as well that you were going to raise it here. And the reason I've stood up is because the estates and transport is part of my portfolio. I won't profess to know the Bristol bus system particularly well, but what I can commit to do is to take your concerns. If you send your script into the team, I'm happy to take that into a monthly meeting we have with the West of England Combined Authority, Bristol City Council, and make sure that your concerns are raised in that setting and through the council in particular, attempt to pick up a dialogue with bus service.
Do you want to follow up on that? Yeah. Mm-hmm.
Thank you so much for that question. It's incredibly important. I'm a new governor. There's quite a few of us here today. This is a question that the governor keep raising. We have David Wilcox, who is a councillor on the City Council at the moment, and he has also been looking into it. It's not really acceptable, is it? But we keep pushing for it, and it's disappointing, I guess, that you were a governor 10 years ago and it still hasn't been resolved. But rest assured, the current governors are still pushing, and we will continue to push. But thank you, Neil, for your offer as well.
Thank you very much. And there was a second question we were alerted to do with the merger and consultation. I don't know if that person's in the room. Okay, maybe we'll come back to that then if we've got time. Are there any other points that people would like to raise? Lady here.
I'm just concerned with the rise of the far right and the marches, and so many staff in hospital are from a different community. And I wonder what your plans are to protect them, support them. If the worst comes to worst, there's a demo outside, how do they get home? That sort of thing. I wanted to know that you have some sort of thoughts or plans about it.
Thank you. Can you hear me? Yeah, okay. Hello, everyone. I'm so sorry I'm late. Talking of transport, I'm afraid the very gods conspired against me today with delayed trains and a bus strike and then a total absence of taxi. So huge apologies for being late and running up the hill to get here. Still was very late. Fantastic question. So as Ingrid mentioned today, I was at a meeting with the Secretary of State, and we nationally the Chief Execs brought up that in the last few months the rise in verbal and physical assaults to staff in the NHS has gone up incredibly because of anti-immigration, so-called free speech rhetoric, which has really focused some very negative actions towards NHS staff, other public sector, and generally in society. What the Secretary of State Wes Streeting said today is that the NHS will be fully supported to take decisive action against people who assault verbally or physically our staff. We've got lots of campaigns of support going on within the hospital. We've got outreach into local community faith groups as well to support staff in different ways. Clearly there will always be some exceptions, particularly where people are suffering with poor mental health, and as a result of their mental health they're making some, they're perhaps not in control of their thoughts in the same way. But generally, there will be decisive action, red cards, and unless it's a case of life-saving behaviour, if people are threatening, then they will not be allowed to use services that are paid for by the taxpayer.
I read, and I know it's not quite the same, but at St Thomas's Hospital, where there was a lot of really nasty language that was outside, the staff continually had to listen to, and then treat some of these people. What I want to know is that it's a bit late once they've been assaulted. You know, it's not ideal. So I want to be assured, if you like, that there are plans, should something happen, that you can actually get them out of the building, or they can sleep there that night rather than trying to get out, whatever, some sort of leadership so that they feel confident that if they come to work, the worst comes to worst, their back's covered.
Absolutely. No one should come into work to be abused or even on their way there. And unfortunately, over the last few years, we have had a number of those incidents outside the hospital too. So we work with police, community support organisations, with our own unions, of course, and then staff are able to gain access. But certainly if we were in an emergency situation, we would go into our full lockdown internally inside the hospital. But thank you for that inquiry. It's nice to know that staff are supported in that way, but it really is a problem, and I was very glad that Secretary of State did address it today.
Are there any other points that people raise? I would like to go back to the murder one, although the person isn't here, but go ahead.
Hello, thank you. I'm Tom Aditya from the Bristol Multi-Faith Forum. I understood the point you raised. It's the issue of understanding harmony, into understanding other people, understanding the other cultures. You know, that's also the solution to that. We have a program called Diverse Doors Open Day, which is actually going from one place of worship to the other. It's a multi-faith trail, and also different cultures, different food, different backgrounds. So that will be as part of the Interfaith Week, UK Interfaith Week during November. So this will be happening in Bristol on the 16th of November. So if the NHS Trust want to actually support that, that'll be great. We are happy to really take few people from the NHS and other groups, so that it'll be a point to actually educational thing, orientation. Yeah, that'll be that's what I want to raise. Thank you. Thank you for the opportunity.
Thank you very much. That's very helpful to know. And both Trusts, MBT and UHBW have committed to being anti-racist organisations with programme of training going on, which is mandatory across all our staff. So it is our duty as public servants to learn, to educate ourselves, to pass that learning on, and we're very grateful for any community support we can have and to access that. So thank you.
Thank you. I'm not seeing any other hands, so maybe we will address the question that was put to us in writing, which was, we are planning to merge. It is a proposal on the table. How are we going to engage with the people that we serve, the public, on the way that we take that forward? I think, Paula, you were ready to respond to that, unless you want to.
Well, I'm sure we're going to say something. Well, do you carry on?
We do a double act. So really good question. I think the first thing to say is, as part of the merger, the proposed merger, will be exploring exactly sort of what that looks like, how we can build on all of the work and all of the engagement we had with people when we wanted to form a group. So we won't be starting from scratch. At this point in time, we aren't planning and need to have any formal public consultation about major changes to services or anything like that. I don't know if the question was directed at a service change consultation or just a kind of a general, but it is really important to us. We've referenced the community participation group several times, so being able to hear the views of the people who use the services directly, who have that lived experience, or who are part of organisations that represent large communities, is vitally important. So we will use the community participation group. We've got the governors, obviously. Ben has talked to us about the role of governors at UHBW, for example. And so that representation of the communities across BNSSG comes from our governors as well. And we also had a major partnership event as part of forming our group, Maria. And I believe we've got a follow-up event proposed. And that's a really big event that allows us to engage very widely with partners and community representatives to hear what people think about what hospitals of the future should look like. Is our role in prevention and health equity, and therefore how, in coming together as one organisation, can we achieve that further and faster?
Any other thoughts before we come to a close? Okay, I would just like to say, oh, is there someone? Ah, Sandra, yeah.
Okay, first of all, it's quite exciting, the thought of the merger. But I'm just wondering if there's an indicative timeline, because I think there's scoping happening now and then there's due diligence, presumably, and it's pretty big, isn't it? I mean, because it's such a large organisation, or two organisations you're bringing together. Is there an indicative timeline for when you would like things to happen?
There is. Hello, Sandra. It takes about a year to go through all the processes for due diligence, and that includes quality impact assessment, equality impact assessments, engaging with all the groups that we need to make sure that we're hearing people's views going forward. We think even with a very fair wind, we're not going to be able to do that before probably this time next year, around about July, August. That gives us really good time to rehearse where we want to go. You'll also be aware there's a very changing landscape at the moment as we look at neighbourhood health, as we look at integrated healthcare organisations. There's a lot to take in to make sure we're doing the right thing for our local population.
Thank you. I really am not seeing any more hands, so I think we will draw to a close. So thank you for being here. Thank you for your support and for your interest. The first words of the NHS Constitution I quote often because they are these: the NHS belongs to the people. This is your NHS, it's my NHS. We couldn't do what we do without your support, so thank you. Thank you to my board colleagues who have been tremendous throughout the year. Also to the governors for UHBW who have given huge amounts of time and are very generous with their support as well. You can get involved with us more. You can become a member. There's a table at the back. It means you'll get really regular information from us. Actually about both trusts now that we're a group. And also we do hold board meetings in public every other month. If you don't want to bother coming to the actual meeting, you can watch it on the video afterwards because it's always up on the website. So there's a number of ways that you can keep in touch with us and hear more. But please do accept my gratitude and thanks for your support. It's been very welcome tonight. And again, big thanks to all the partners that helped with the health fair at the beginning. I thought that was fantastic. It had a real buzz in the room, didn't it? Yeah, even if I am a bit worried about my wrong sort of cholesterol, worth it. No more cheese for me. Okay, thank you all very much and good night.